Hello, everyone. Thank you so much for joining our panel. I'm going to go ahead and share our slides so you can see those. Okay. So we're going to go ahead and get started because we have a lot of information we want to share with you all today. So I'm going to do a quick intro to our panel and then get to the introduction. So first of all, why focus a panel on lactation? This is a common thread among the stories of different survivors. I've been fortunate enough now to meet many survivors through my work on the PSI, Postpartum Psychosis Task Force, PSI's online peer support group for psychosis survivors, and some other like networking and some Facebook groups as well. And so there's a wide variety of stories that people have about their lactation experiences. One of the most common ones we hear is, I became sick, was separated from my baby or needed medication or other treatment, and I was discouraged or kind of forbidden to continue lactating or breastfeeding, or from like establishing breastfeeding. So kind of like a refusal to support. And then in some cases, we've got some people, they've weaned their baby or stopped lactating, and that's been one of the hormonal triggers for their illness to begin. And then you've got some other survivors that I've heard stories from where they've maybe planning another pregnancy or right in their original recovery, and they've chosen to stop lactating and formula feed, and they're facing some criticism from others for making that decision. So one thing I think that runs throughout all of these different types of stories is that the care is not prioritizing the goals of the parents or the families. And sometimes the caregivers, which can include the healthcare providers or the family members, they might lack awareness of some of the unique considerations about lactation and infant feeding. Just because there's an alternative source of food for a baby, which is amazing and powerful and it's so great, we still have to understand that lactation isn't just a food source. So our goals in this panel, the three of us, is to educate kind of a broad audience. So that's including survivors, maybe those who have been learned they're at risk of postpartum psychosis, any of their loved ones, caregivers like doulas, lactation consultants, healthcare providers of any kind, just about all of the unique ways that lactation and postpartum psychosis might intersect. And then by providing that knowledge, we're going to pave the path to more collaborative care in the future. It's goal-centered care. Which brings me to my introductions with the team that has come together to do a beautiful job providing some information to support those goals. Just to introduce you to myself, I'm Sherry Westman. I am a doula, parent educator, infant feeding specialist, and just overall supporter of parents. And also I am a postpartum psychosis survivor and advocate. Today with me, I also have Olivia Reichenbacher, a practicing psychiatric mental health nurse practitioner and an adjunct assistant professor at the University of Virginia School of Nursing. She specializes in caring for women during pregnancy and postpartum. Celeste St. John Larkin is also here. She's a child, adolescent, and perinatal psychiatrist and an assistant professor at the University of Colorado School of Medicine. She's the medical director of an outpatient program for pregnant and postpartum mothers and their infants at Children's Hospital, Colorado. And also joining us today is Lynette Hafkin. She's been a lactation consultant for 17 years, supporting families in both hospital and private practice settings. Lynette is also the director of support services for the Fed is Best Foundation. So first up on our presenters is going to be Olivia.
Thank you, Sherry. All right, so I'm going to be talking to you all today about lactation in the context of medication treatment for postpartum psychosis. I'm so excited to be here to do this. It's going to be a bit of a whirlwind. There's a lot of information. But I think my hope is kind of what Sherry already echoed, which is that you walk away from this today just feeling more empowered to work in partnership with your provider to make the best decision for your specific circumstances. Providers, I hope you walk away with a better understanding of how to engage in this decision-making process with your patient and really center it around them. Unfortunately, I don't have time to discuss the information that we have on specific medications and their safety in lactation. But fortunately, that's really only a small part of sort of the overall decision on whether or not to breastfeed in the context of postpartum psychosis management. I think we often get very stuck on that as the information that is sort of the only important factor, but ultimately this decision is one that should be examined much more holistically with consideration for medication sort of only as a portion. So you all will get some resources, probably Sherry will direct you all to them, that you can use to sort of help find information specifically about specific medications and what we know about them in the literature. Providers, there's also going to be sort of a heuristic process available to you that might help with this decision-making process. I also want to quickly note that I use the words breastfeeding and lactation kind of interchangeably, but what I'm really talking about is lactation, which is like feeding the baby at the breast, pumping, could be producing breast milk, but deciding not to feed the baby the milk at all, just all of those things, okay? All right, so Sherry, you can go ahead and advance. You can go to the second slide, actually. Thanks. Okay. Okay. So to start off, I do want to highlight a couple of things. So I think it's really important that we understand that medications really are sort of the cornerstone of treatment for postpartum psychosis and also for managing the underlying illnesses that can cause postpartum psychosis. Some people do have non-medication treatments as part of their overall treatment. Sometimes, for instance, something like electroconvulsive therapy in acute psychosis, things along those lines. But really, this condition is one that, 99.9% of people are going to need medications to really effectively manage the condition. Also, it's really important to understand, and I know this is not, this is something that survivors and their families understand inherently, but for those who might not have as much familiarity, postpartum psychosis really is a very severe mental health condition. We really consider it kind of a crisis in psychiatry. And it really involves oftentimes concerns for the safety of mom, sometimes others around her, including baby, and many other consequences, not least of which is that this can be a pretty traumatic experience for many people and their families. So I think that given that, understanding that medications are really this cornerstone, that postpartum psychosis is really a very severe condition, our priority is always going to be to get and keep mom well. That is the overarching goal of all treatments. And so that's kind of where we jump off from in this decision process for deciding whether or not to lactate. Okay. I think it's really important to point that out because sometimes we're in situations where the decision might be like, do I take a medication if I'm going to breastfeed? Whereas here, the decision is really more like to breastfeed or not. And if so, what are the most appropriate medication options for me and my provider to select, or how does the medication I'm currently taking weigh into that decision, rather than like, do I breastfeed or not, right? Or I'm sorry, rather do I take medication or not? Okay, thanks, Sherry. You can go to the next one. So the most common medications used in the treatment of postpartum psychosis are antipsychotics and mood stabilizers. And depending on someone's specific symptoms or illness, they may also take other medications like antidepressants or anti-anxiety medications, really any other psychiatric medication, depending on that person's needs. What I'm going to be discussing today is really about this decision-making process, which should apply to all medications, right? I will spend a little bit of time talking about some specific medications in the mood stabilizer and antipsychotic classes. And I, again, for time constraints, don't have time to really talk extensively about other classes, okay? So coming to the decision of whether to breastfeed or not, again, is a very complex one that truly has no right or wrong answer. I can't overstate that. This is first and foremost about your individual needs, including your symptoms, the type and course of illness, the severity of your symptoms, your preferences, your priorities, your values, all of those things. I think secondarily also about your baby's needs and also potentially your family's needs as it relates to lactation and your medication and your treatment overall. And I think the biggest myth that I hear is that, like, if I take a psychiatric medication or if I've had postpartum psychosis, I can't or shouldn't breastfeed. What I hope you walk away from today is understanding that that's really simply not true. There are, of course, medication options that would be considered more favorable for breastfeeding, and even at least one that I'm going to discuss a little bit briefly that I would consider to be truly a contraindication. But by and large, I would say most psychiatric medications, including those that are most commonly used for postpartum psychosis, are compatible with breastfeeding. Okay, next. So unfortunately, though, we don't have the kind of information on these medications and breastfeeding to be able to say with certainty that they cause or don't cause X, Y, or Z, okay? Instead, what we have essentially is imperfect research, okay? It gives us some very useful information. We have some really good quality studies that tell us a lot, but it still leaves us with some unknown risks as well. This is why, I've sort of said quote unquote safety earlier. It's because I can never really say hard and fast a medication is safe or not. The best case scenario truly for a medication is that we would have a lot of information from very well done studies that does not show any major concerns for exposed babies, but there are always going to be some unknowns. And this is not to scare you or to make you like more weary of breastfeeding while taking medications. In fact, I think hopefully this will help you to see that there is no perfect decision and that the decision is often going to be coming down to other factors that really are not specific to that medication. So in that light, like, what are some things that we should consider? You can go to the next slide. Thanks, Sherry. Yeah, what do we need to consider when it comes to making a decision about breastfeeding in the context of postpartum psychosis treatment? I think first, we do need to consider those known and unknown risks of medication to the child exposed via breast milk. We do, when possible, try to use medications with the most available literature support. While it's not the only factor or even the determining one, it is important to consider this aspect, and it can help us to make better decisions about specific medications we might select for postpartum support treatment. And in general, can help us to feel like we've made a more well-rounded decision when it comes to if somebody's already taking a medication and the decision that might go based on that, okay? We also want to consider the risk of not treating with medication or the benefits of treating with a medication, okay? So for postpartum psychosis, again, this is less about the overall decision of whether to use medication or not. It's more about evaluating perhaps specific medications as compared to other options, right? So for example, like, what is the risk of not using a medication that works really, really, really well for me, even though it has maybe less research about its use in lactation than something else? Or what could be the benefits of using another medication, right? That's kind of how we're thinking about this particular consideration. I think what is far too often overlooked is, and really just not given enough attention to in general, are the risks and benefits of lactation itself. You're going to hear more about that in depth from Lynette, but I can't overstate this. The decision should not be only based on the medication, right? We have to consider the other factors in this, which are potentially the benefits of lactation for first and foremost mom, also baby, potentially the family unit. And additionally, what, for instance, could be the risks of stopping lactation? So for example, and Sherry kind of mentioned this already, we know that the hormonal changes of weaning can be destabilizing for some people. Anecdotally, there are survivors of postpartum psychosis who have experienced lactation as essentially chemically beneficial for their mental health, right? Whatever protection that provides for their hormonal changes seems to be potentially beneficial. I think also it's important to consider, like, if we can't support weaning appropriately, if weaning is the direction we're taking, like, this is potentially a risk of cessation of lactation too, that mom might be at risk of things like mastitis or other consequences. The last thing I think that is really important to consider in this whole risk-benefit analysis is what are the risks of lactation? So, again, first for mom, then also maybe for baby in the family unit. And again, although my main goal here is to sort of dispel the myth that you can't lactate while you take medications, I also want to be clear that it's certainly not the right choice for everybody or in every context. Some people find lactation to be very challenging, very emotionally overwhelming. That combined with the already extremely challenging and emotionally overwhelming experience of postpartum psychosis, sometimes is not the right mix. The main concern typically with lactation and in the context of somebody with postpartum psychosis is really as it relates to sleep. So sleep is probably, I would say, the single most important non-medication related factor that would affect someone's illness, their course of illness, and like how easy it is to keep them well. So it's certainly something that we do need to consider. There are some people that they recruit all of the help they can for overnight feeds, for care of baby overnight. They prioritize protected sleep as much as is humanly possible, and still just the act of lactation and all that that entails and all the requirements of that can prevent them from getting good, consistent, high quality sleep. But there are other people for whom breastfeeding actually helps them to get more and better sleep. So we do need to factor that in. And if sleep is being impacted, that's certainly something that should be considered. Okay, so this is the last thing. I just want to shout out a couple of medications here that I think you might want to just know a little bit more about, so you can consider some of these factors in relationship to taking these while breastfeeding. The first is lithium. It's just very commonly used in treatment and prevention of postpartum psychosis. I note it here because it does involve blood monitoring. And so oftentimes pediatricians will also want to monitor the baby via blood work for things like blood levels or potentially other monitoring. So it's just good to know that that might be involved, and that could be a determining factor about either whether to use this medication or breastfeed or not. Secondly is valproic acid. This is probably the only medication off the top of my head that I would consider truly like a hard contraindication for breastfeeding of these categories, right? We just have truly overwhelming evidence that this medication has very negative outcomes on neurodevelopment for babies in the womb and also for children who take this medication. It's not that there's as much evidence about outcomes in lactation. It's just that the other evidence is so overwhelming. And in general, we consider this medication to be contraindicated of anyone for anyone of childbearing potential. You'd be hard pressed to find anybody with training in reproductive psychiatry or perinatal mental health who would say that valproic acid is an appropriate medication for somebody who is of childbearing potential. There's also not good evidence that this actually helps prevent future episodes of postpartum psychosis. Whereas other medications we might use do have that effect. So all in all, there's not a whole lot of potential benefits maybe, and a lot of risk. So I do consider this to be pretty much a contraindicated medication for lactation. As far as the antipsychotics go, I like to point out that Abilify, it's actually quite well studied comparatively to other options. It does, however, reduce prolactin levels, which can decrease milk supply. And that can be very important for somebody who really wants to establish and maintain a breastfeeding relationship. I have had clients for whom the reduction in milk supply was so severe that it prevented them from lactating at all. Other clients, it's just a small reduction and they continue lactating. This obviously could still be a great medication option for some people. It's just a consideration that needs to be taken into account. And then the last one would be Risperdal. And this is a medication with sort of the opposite effect of Abilify, and it can increase prolactin, which can lead sometimes to oversupply. And oversupply comes with its own risks like mastitis. Risperdal has been linked independently to mastitis, even in people who are not postpartum. Other antipsychotics also increase prolactin. Risperdal is just one that I kind of wanted to shout out because it's a little bit more commonly used for treatment of postpartum psychosis and one of the bigger offenders. And I'm sure I'm over time, so thank you all so much. And if you have questions, please feel free to ask them and we'll try to get to them.
Thank you, Olivia. I wanted to call out that in the chat, I'm letting you know that you can type in questions in the chat or put them in the Q&A. We won't be doing any audio from the participants at this time, and I'm not sure if we'll be doing that at the end either, but we're going to think mostly just go by typing in your questions. So our next presenter is Celeste St. John Larkin about treatment options. Thank you.
Great. Thank you, Olivia. That was a great summary of a lot of difficult information to talk about. So great job squeezing it in. You can go to the next one, Sherry. I'm going to talk about the other kind of psychosocial treatments that are often needed and safety treatments that are often needed in postpartum psychosis or severe depression or bipolar disorder postpartum. So often, as you all know, it is a psychiatric emergency if there is psychosis present. And women often do need to be hospitalized, hopefully for as short a time as possible, but also can help really help women turn the corner and improve and be safe in all regards. So some of the different levels of care that people aren't always aware of. So hospitalization, it's a 24/7 setting. There's behavioral health staff and nurses there all the time. But there's also partial hospitalization, which is a day treatment model. So it's ambulatory, you go home at night. There are models for this that are perinatal specific that we'll talk about a little bit. It's usually 4 or 5 days or half days per week, generally at least 20 hours for insurance to cover it. And then intensive outpatient is sort of a step down from that. That is group or individual therapy, at least 9 hours, sometimes up to 19 hours a week. Usually it's kind of 3 hours in a group and individual setting, about 3 days per week, sometimes in the evening, which can work with people who need help with childcare from spouses or partners. And some of these things can be options if a woman is not needing to be directly hospitalized, that maybe can prevent hospitalization if they get other intensive support and treatment, or as a step down from the hospital. Okay, go ahead. So as far as perinatal specific units in the US, other countries have a lot of mother-baby units, as you can see there, which I got from a Health Affairs article that actually featured our sponsor for the day, Christina, talking about how there are programs where you can actually be hospitalized with the baby, and there's, care for both mom and baby, and definitely that's ideal for supporting lactation. However, we do have some perinatal specific units, so they don't host the baby overnight, but they may have extended visiting hours and other support, pumping and other lactation support available in these settings. So I'd encourage you to look through those, and they have really kind of great lists of other things that are possible when we focus on moms and babies together. Yoga, spiritual support, nutrition, dyadic and attachment therapy can be involved. So go ahead to the next one. So there's ideal things, and then there's what's available everywhere else. So there are 14 states that have specialized day hospital or intensive outpatient programs, and those are listed on the PSI website. So I'd encourage anyone who's needing more intensive support now or in the future to look those up and reach out. But where I am in Colorado, we don't have a specific program, but we do utilize other non-perinatal programs because they focus on, DBT, CBT, other, important therapy skills that people need and may have some intensive psychiatric treatment. But ideally, maybe someone completes this, a non-perinatal program while they're getting also specific treatment with a perinatal psychiatrist or therapist, or they do this acute treatment and then can step down to a outpatient level of care with more specific perinatal focus. Go ahead. So some of the barriers of women accessing hospital care when it's needed, and this is in general, not just for postpartum psychosis, but also especially a factor, reluctance to discuss difficulties parenting, fear of losing custody or access to baby or children. And as we talked about, it is a trauma to go through postpartum psychosis, and many women find just being separated from their infant at the hospital is an ongoing loss or trauma that they deal with over time. So it can be difficult to know how long you're going to need childcare, how long are you going to be in the hospital, because the discharge date is not always clear. Is there other family support around if the partner, or if there's no father or partner involved, who's going to take care of the baby while the mom goes to the hospital? Also on the unit, there may not be, I'm originally a child psychiatrist, so I feel like we do family meetings a lot, and units are sort of set up for kids, but on adult psych units, can be really different and scary or intimidating for some folks. And having a place for family to visit, or a place where moms feel safe bringing their children to visit, can be a challenge. So that's one of the things we'll discuss as a recommendation. And then, sometimes the attitude or stigma about motherhood and mental illness can be really a challenge. And then I think during COVID, especially, any visitors were often restricted, let alone having infants visit was probably not happening for the past couple of years. So thinking about what barriers are there. One of the biggest things that we discussed when we were planning this panel, and that many of you are aware of, there's no standard policy for supporting lactation or dealing with personal breast milk in psychiatric hospitals. Nurses don't have policies for it. Staff isn't aware of, that it might even be happening for some moms who are hospitalized in the postpartum period. In addition, there's lack of education and training for psychiatric or medical providers. It's not a perinatal mental health or rotations with pregnancy and postpartum, unfortunately, is not a required rotation for psychiatrists in residency. So I think it's not something you necessarily get unless you seek out or happen to be in one of the national centers that has those options. And then lack of recognition that there are options. I think, like Olivia was saying, it's a really individualized, personalized decision, whether you initiate or continue breastfeeding. I think there's also, when I see people as an outpatient later, it breaks my heart if they were told they had to stop breastfeeding kind of abruptly in the hospital, but really, in my knowledge, they could have continued breastfeeding on that medication, but then it's kind of too late to restart. So one of the best things might be just to pump temporarily and decide later about feeding that milk to the baby or continuing, or if there's, as we mentioned, needing support for discontinuing if that's what needs to happen or what the mom prefers. Okay. So thinking about, we also wanted to empower families to think about what might be needed if a family member or one of your patients is hospitalized. So who's going to provide the breast pump? If it's a hospital that is affiliated with a psych unit that's affiliated with a large hospital, they should be able to provide it from the nursery or the NICU. But if it's a freestanding psych hospital, the family may need to bring in the pump from home. Luckily, pumps are usually covered by insurance now, so that most people can access one more easily. Where will the milk be stored? So people sometimes on, hospitals, there are specific places for patient food and staff food, and where does breast milk fall into that? It's not considered a bodily fluid, so it doesn't have to have the universal precaution. So it can be stored in a refrigerator with other food, maybe even temporarily, and then family could transport the milk back home periodically if that's an option. How are pumps going to be cleaned? I did want to point out, as many of you may know, cleaning with soap and water is accessible. They don't have to be sterilized by hospital standards. So that's one thing that sometimes could be a barrier, which we can inform the hospitals about. So other considerations, is there access to a lactation consultant or OB or midwifery care in the non-specialized units? That may not be something that's regularly on their radar to ask for. So bringing that up, I'm thinking telehealth could be a good option to get lactation support or to reach out to OBs or midwives if needed. And then awareness of, what is required to stop lactation, especially in those first weeks postpartum. If someone's deciding not to breastfeed, they need support in maintaining comfort and safety and decreasing that, and also addressing the emotional pieces that go along with that. And then asking about other support groups for partners, fathers. Those PSI support groups are available online if there aren't things set up in the hospital. Okay. And then some recommendations, just increasing staff and provider awareness that breastfeeding can be an important part of recovery. So if there has been a separation, but mom was able to continue pumping, it could be, really an important part of reconnecting with the infant if that's going well and could be supported. Or acknowledging that it's a loss that they're not going to continue to do, and acknowledging that as part of the therapy treatment. As I mentioned, family rooms to visit in a safe place, maybe not directly on the psych unit for infants and children, is important. And then a private but supervised space for pumping. I think some of the thought that psych hospitals may have is, is this a safety risk to have the pumping materials or hoses or cords around? But I think it can be done in a supervised setting. We also were thinking about, if we had a national movement around this, identifying a nurse champion or somebody who's a champion at each psych hospital to support these sort of things would be really ideal. And then allowing frequent and extended supervised visits with the infant and with family could be really important. And that happens in the specialized units, but encouraging this or encouraging people to think outside the box at the non-specialized units can be important, because it's also helpful for staff to see the progress of mom interacting with the infant. and also what support is there and education for the family can be provided in those visits. So. And then just one last thing on other ways for families to or patients to advocate for the most up-to-date and accurate information that the providers could have. As we talked about, some psychiatrists don't know the latest on the medications and the risk-benefit ratio and how to weigh that out as well as experts do. So we'd encourage them. You can mention to the psychiatrist or the team that's working with you at the hospital, can you call this MGH postpartum psychosis consult line? There's also the PSI provider consult line, and several states, the dark purple ones on this map have either federal or state funding to have a full access program where any provider in the state, healthcare provider, can call and get consultation. And then other ones are working on having it. And there's actually a bill in Congress right now that I'll put a plug in for into the light that would support having funding for all the states to develop that. So, and then there are female specific units in some cases, even if you can't find a specific perinatal unit, that can still seem a little friendlier. All right, thank you.
Thank you so much, Celeste. Right, next up in our lineup is going to be Lynette, and our IBCLC is going to talk a little bit about some options for managing breastfeeding.
Thank you, Sherry. First of all, I'm really happy to be here, and I'm looking forward to sharing this information with everyone, and I hope you find it helpful. So breastfeeding and lactation are things that are usually pretty important to mothers. When there's an issue with postpartum psychosis, you may experience disruption to your milk supply, issues with latching, bottle rejection, separation, and scary and overwhelming feelings that can go along with what's happening with feeding. And the main thing I want to get across is that there's a path through this for you and for your baby, and we will find a way. There are people that help you, and we have resources that you can use to help you figure out what's going to be right for you to move forward. So I find it really helpful to have parents think about why they wanted to breastfeed. What does it mean to you to be a breastfeeding mom? Often people may have some ideas, but haven't really thought about all the details and the things that their expectations. What is breastfeeding going to be like? Here are some typical answers for why people want to breastfeed. And I'm going to be addressing health benefits, risks, things like that later, and bonding. And we do have some information available in our resources section that will be really helpful, particularly the one that discusses benefits and risks of breastfeeding versus formula feeding, combo feeding, whatever you're doing. So next, I'm going to talk about why it's helpful to really think about what lactation and breastfeeding mean to you and why you want to do it. It's an opportunity to clear up misconceptions that you may have. Many people think of breastfeeding as free, and it is not always for everybody. Minimally, you're going to have extra food costs. But some people find that if they experience problems with breastfeeding, they're going to be spending a lot of money on lactation consultants, on various supplements that may not work and probably don't, and supplies that they need, nipple shields, breast pumps, flanges. They also might hear that formula is easier. You should just formula feed if you have a postpartum disorder. You'll get more sleep. This may be true for some people, but it is not necessarily true. Previously, it was discussed that some mothers do get more sleep when they're breastfeeding because it's relaxing. You can do it lying down, and it can, the hormones of lactation can also be just, help you fall asleep and hopefully not in bed with baby, but it's, you know, a thing that's very individual. In terms of bonding, bonding is not related to feeding method. We have research showing this, and it's common sense also. However you're feeding your baby, you're interacting with them, you are showing them love and care and shared experiences with your baby, whether reading, playing. Those things are what help you develop a bond with your baby, not how you're feeding the baby. It's also helpful to think about why breastfeeding has been important to you, because after the baby's here and you're actually doing it, is it providing what you expected or hoped for or wanted? And have your thoughts about feeding changed since your baby arrived? Thinking about this can also focus your attention on your priorities. For some mothers, their priorities are making as much milk as possible. And for others, they're not so focused on milk supply, but having the baby at the breast and just experiencing that connection. So let's get back to health benefits and risks. There are benefits associated with breastfeeding. In particular, a lower risk of gastrointestinal illnesses and respiratory illnesses. But one thing that people get really scared about is SIDS. People hear that breastfeeding reduces the risk of SIDS, which it does. This slide here is from the American Academy of Pediatrics. And what you see here is that, yes, breastfeeding reduces the risk of SIDS, but so do pacifiers. You do not have to breastfeed to help your baby have a low risk of SIDS. And that should not be something that scares you or makes you feel like you must breastfeed or else your baby's unsafe. No, pacifiers do just as good of a job. The other thing about health and effects of feeding method, a lot of the research we have on breastfeeding benefits, formula risks, however you want to think about it, are correlations. We can't determine whether breastfeeding causes a particular health outcome, or if there's just a relationship that may not be a causal relationship. If you look at this slide, obviously there's a relationship between cheese consumption and people dying from becoming tangled in their bed sheets, but it's ludicrous to think that one caused the other. So a lot of the research is showing us more that breastfeeding mothers are wealthier. They have more likelihood to be successful with breastfeeding because they have good access to support. They usually don't have to go back to work so early. They have better health care, which is the thing that could be responsible for better health outcomes, not necessarily the fact that they were fortunate enough to get the support they needed to breastfeed. Whereas if you are very low income, you are less likely to be successful with breastfeeding, unfortunately. Very unfair, but unfortunately, in the US at least, there's very little support for mothers to continue breastfeeding when they go back to work, or even early on when they're trying to establish it. It's hard for low-income families to have access to good lactation care. And likewise, people in poverty would have less access to healthy food, less access to safe places for their children to exercise outside. So it may not be the formula that causes, for example, higher weights in children. It may be the fact that they do not have the same access to healthy food and exercise. And the poverty is what caused the difficulties with lactation. So Now we're going to talk about what good lactation care looks like for someone experiencing postpartum psychosis. And I hope this will be helpful to any professionals watching for honing in on how you want to help your clients, and for those who are at risk of a postnatal mood disorder. This can help you evaluate potential consultants that you might work with. The most important thing, I think, is that your consultant be focused on your goals, what you want to get out of this relationship with your consultant, with your breastfeeding relationship with your baby. And she should not bring her own goals into it. She may be very, happy about people breastfeeding exclusively, but when she's working with someone, the patient's goals need to be front and center. So it's also very, very important that there be no judgment, not even silent judgment, because patients can usually tell if someone's judging them. And there are so many lactation consultants out there that will be really, really good at working with mothers because, we are the ones that see how difficult it can be to manage feeding your baby, especially with how common things like postpartum depression are. Sleep and self-care is also something that should be a top priority. Because not only because you are important and you deserve to be happy, but also because if you are healthy, well-rested, and have your cup filled, you can take better care of your baby. Your lactation plan should also address whether you're enjoying feeding your baby or not. It's supposed to be enjoyable to you and your baby and to be a bonding experience. And so you can explore with her what you're finding pleasant about how you're feeding your baby, what you're finding is not enjoyable or stressful. So number 4, if you're familiar with the Fed is Best Foundation, we provide a lot of education on how to protect newborns from the risks of not getting enough milk. I don't want people to feel like this is probably something that's going to happen to their baby. It's not likely, but it is a thing that can happen. And when we have a situation where someone is at risk of a postpartum mood disorder of any kind, anxiety, depression, psychosis, anything like that, we want to take this off the table as something that could ever happen. You can imagine the stress that would be involved of having to hospitalize your newborn because they got dehydrated, for example. So even though I don't want people freaking out about that and thinking that something like this is probably going to happen, it's not. It's, relatively rare, but it happens more than we want it to. So it's something to be aware of and work with your consultant on how to make sure your baby is getting enough to eat and drink. Your plan should also protect your future ability to breastfeed if you're hospitalized. And we're going to talk more about that because it can be really difficult. As previously mentioned, hospitals often don't have a policy for lactating patients. And also, your consultant should help support your relationship with your baby during your hospitalization. Because breastfeeding is not just all about providing milk, your baby drinking milk, latch, those kinds of things. It's also about a close relationship between the mother and baby, and there needs to be some kind of connection, whether through video chats or bringing some of the baby's clothes to mom so she can smell them, because that's really nice, and also it can help increase your output when you're pumping. Here are some other things that your lactation consultant should do. First of all, it's very important that she become part of the healthcare provider team, get contact information and whatever legal releases need to happen so that they can work together as a group. And this is important because patients often get conflicting or confusing information if things aren't coordinated. And it's also important because this reminds your healthcare providers that breastfeeding is something important to you, and that it should be important because you're their patient. You can also expect her to advocate for you getting the things you need by communicating the risks of not providing your pump or access to your baby, risks such as mastitis, pain, emotional anguish at not being able to see your baby. And you may need some resources or supplies, such as a hands-free bra or one of your baby's stuffed animals to help you cope with the separation. It's also important to ensure that your supporters understand what the lactation plan is and what their part is, because this should not all be on your shoulders. Assign someone to wash your pump parts. It seems simple, but it can be really, really helpful to have that just taken off your plate. Have somebody sit with you while you pump so you don't get lonely. And here's some information about how to find a supportive IBCLC. And there are a lot of them out there. I think that the support person should offer to do the legwork of sifting through the many people that are out there and trying to find the one that seems like they would be most appropriate for the person suffering from postpartum psychosis. And here's some ways that this person can start looking for a lactation consultant. If you have access to any therapists who are experienced with postpartum mood disorders, they might be a really good source of how to find a lactation consultant that would be very gentle, compassionate, patient-focused. And also moms groups in your area are a good place to start. And someone, either the support person or the mother, should take that short list of potential LCs and interview them on what the mother's specific needs are. And it's important for the mom to at least briefly chat with some of these people so that she can see if she clicks with them or not. Because this is a very trusting relationship where mothers are very vulnerable. They need to feel like they can trust that you will be honest with them and you will not judge them for, not pumping enough or something like that. Okay, so I have a list of sample lactation plans, and I'm just going to zip through them to save time because you're going to have a copy of these in the resources folder. But I will say that creating a plan should be a dialogue. It should not be a kind of cookie cutter, one size fits all thing. So these are just sample plans just to show you that there are ways to breastfeed in ways that are going to be right for you. It's not all or nothing. There's not only one way to breastfeed. If part of your plan, can you go back for a second, Sherry? Thanks. If part of your plan is involving some formula or bottles, many times people have anxiety over that because they are afraid they will be judged. And they have a right to feel that way because there is a lot of judgment on mothers. So if you feel like you have some anxiety about the way that you choose to feed your baby, it's a good idea to practice how you would respond. Have a phrase that you would want to use, such as, how I feed my baby is a personal decision, and I'd appreciate support with that. And this is what's best for my whole family. And if you are a little angry, you can also just respond with, wow, and then silence to show them how inappropriate it was to make such a judgmental comment. Okay, next slide. So supplementing with formula is actually one of the most common ways that people breastfeed around the world. And it's okay to do. Basically, I'm not going to give you the specifics about how to do this. I just want you to know that it can be done. And it is often done. It's okay. Many people like to have their partner give a bottle at night. And especially if you have specific sleep needs, it's important to be able to do this. And with some mothers, they may want to try pumped milk if they have enough of a supply to be able to do that and don't absolutely hate pumping. And one thing I want to highlight here is that it's important not to wait longer than 3 weeks to introduce a bottle. Otherwise, the baby may reject the bottle. Okay. Here is a nice way to breastfeed for mothers that aren't producing a whole lot of milk, but they just really enjoy nursing their babies and they want that connection regardless of how much milk they're using. So basically, it's about using formula for nutrition and breastfeeding for an appetizer, for comfort, for dessert, for bonding, if you feel that it's bonding. And if the supply is very, very low, I try to think of it as medicinal amounts of milk instead of low supply. And the key for this one is to keep your baby enjoying breastfeeding. Some babies get so hungry so quickly that they don't want to mess around with the breast. They just want the bottle and that's that. And in that situation, breastfeeding for dessert may be the right way to go. Other babies are a little calmer and would be fine with taking the breast first and then the bottle for whatever else they need. Okay, so unfortunately, this is something that is likely to happen because, as mentioned before, your healthcare providers are going to be more. I'm sorry, I'm getting a phone call, even though I'm.
I'm going to pick up on Lynette's slide since I think her phone caused her to hang up from the Zoom call. So her and I have gone over some of these things before. So there's a few things that might have happened if you didn't get any support in the hospital for lactation. So it's like no access to a pump or support with hand expression. And if this happens, you need to get your lactation consultant for an individual consult to see what you can do. Some of those plans that we talked about previously, if you have some supply but not much, some of those plans are going to work well for you. And then also, it's perfectly acceptable to choose to stop as well. Hopefully that we've covered some of the information that helps you feel like that's an option as well. You may come out of a separation and feel anxious about getting back into taking care of your baby, holding them and feeding them. You can coordinate with your nutrition. Oh, here's Lynette. Lynette, I just started, I went back into your slides and just started talking about some of these.
I'm so sorry. I'm back.
Right. So I just was covering some of the problems and solutions.
Thank you so much. I don't know what happened there. I was on Do Not Disturb. Can you see me? I don't see my.
Yes, you're up and
just
down.
want to make sure I'm not upside down or something.
Yes. So I'm just on this
Okay.
last item on problems, negative feelings. And then we are real close to their end of time as well. So
Okay. So maybe I'll just kind of briefly say that reframing something like, if you're using formula, it's not failure, it's a tool that you're using temporarily or permanently to help with supporting your mental health and your baby's nutrition, and also grieving what you thought you had been going to do and what's actually happening, and nobody should minimize your feelings over that. These are the things that I would like everyone to keep in mind. Most especially that ideal mothering is not determined by feeding method. Your baby loves and needs you. Supporting your own mental health is ideal mothering. So to sum up, there are many ways to successfully feed your baby. As long as they're getting nutrition and love, then you are officially doing motherhood right. Thank you.
thank you so much, Lynette. That was all super helpful information. And I love this line, you define success. That's kind of our goal here, is just to put some of the agency back into the lane of the parent and the family. And so I just had one quick sum up slide that in an experience, as I said, I'm a postpartum psychosis survivor, in an experience that really takes away so much of your ability to make choices and to understand what's going to happen in your future, that being, having that preservation of your self-determination, your agency, just in something not simple, but something that takes, over your whole days as a new parent, feeding is a constant daily task. And so having some agency and choice in that is really healing and can have a positive impact on recovery. And we thank you all for being here for our presentation. We're going to have a resources page that's going to accompany the recording of this presentation. That's going to be on the Postpartum Psychosis Awareness Day.org website. We're going to also provide some of the links to some of the resources that our presenters recommend, and we can answer some of your questions here. I'm going to bring up the chat and the Q&A if I can get my cursor to go. All right, if we have any, not seeing any Q&A, any questions or comments, please feel free to pop in the chat or the Q&A. And we can have any of our presenters pop back on camera. Or any final comments from any of the presenters, if you've remembered something you really wanted to say, and the floor is open to you all.
The one thing I forgot to say as a side note was asking hospitals about places for families to stay. I noticed that on some of the websites. So Ronald McDonald House, or hotel vouchers, especially if you travel to one of the specialized places, like asking social work at the hospital for some supports can be a good idea.
Oh yeah, Lynette, Sharon asked about relactation, and I think that was we definitely had in our plans about relactation. We have a resource for that. It's kind of a more in-depth option. So I'll just say that relactation means that if lactation has ceased, that you are going to start back up the production of breast milk. And I can actually put that resource into the chat, into the Q&A for you all. Any other thoughts on relactation, Lynette?
Well, it's going to be something that needs to be very individual. So I would just encourage people to work with someone to figure out what is the best way for them to relactate. And it's also something that is doable. You may have varying results with what your milk supply is going to look like. There are no guarantees about what it's going to look like, but it is something you can do. And I think a lot of people are happy that they did it. And, then at least they know they did everything that they could to make breastfeeding work. So it can be easier to come to terms with the fact that it didn't end up working out when you know you have done everything you could do.
Yeah, thanks for that question, Sharon. Okay, so I guess I can hand it back over to Christina. Thank you again all for coming today. And thank you to the panelists who joined me for this presentation. I appreciate your effort and being here and helping me present this information.
Thank you, Sherry.
Thank you all so much for joining us today. Panelists, thank you for your expertise and wisdom on this subject. Everyone that is here with us today, please feel free to like, comment, share, engage with us on social media, help us elevate these discussions, and donate if you can. And with that, thank you all, and we will see you later.
Thank you, Christina and Sherry.
Thanks.
Thank you.